So, just a little bit more about myself and how I got into um, this area of research and clinical focus. As a Black woman myself, I found that going through medical school, residency, fellowship, and working in academic institutions that no matter what I was working on or studying or the patients I was seeing, there was always a gap as it related to Black perinatal mental health or just Black patients who were able to access me. When they were able to access me, there were a lack of resources for me to help some of my patients. Those who accessed me most were those who were were working in the institution, had graduate degrees, had private insurance. Here I am again coming from the U.S. framework, and and I and then working, no matter what group of Black women I was working with, I continued to see where there were social injustices, disparities, and I was always trying to bridge this gap. So that is partly how I got to Canada 7 months ago to start working on that here, which is an extension of what I began working on in Chicago, which is where I'm from. So without further ado, we'll get started here. So disclosures, I'm a consultant for a few different groups, but nothing that really pertains to this talk today. The objectives of this talk, I really want to talk about perinatal mental health disparities, but bridging it to the framework of reproductive justice, but also tying it to maternal health broadly, as well as thinking about it in terms of social injustice in regard to perinatal mental health and the ways in which we can begin to dismantle disparities and achieve equity. So when we think about reproductive justice, we think about the bridging of reproductive rights and social justice. Reproductive rights are rights that consist of individualistic reproductive freedoms regarding sexual and reproductive health. And it consists of three principles, right? So 1, rights to reproductive self-determination. 2, rights to sexual and reproductive health services, information, and education. And rights to equality and non-discrimination. Social justice is a justice in wealth, opportunities, and privileges in society, and is made up of 4 pillars. So human rights, access, participation, and equity. And, I don't know if you guys have been following the news in the US, but when I think about social justice and reproductive rights for that matter, that's a really hot topic right now in the United States as we see the rolling back of right to abortion, gender rights, and then as we see the rolling back of affirmative action, so really ties into social justice as we, think about the LGBTQ community not being able to, it being okay to not teach anything about that in schools. There being laws around that in certain states, and even laws around marriage or who can receive service at different establishments. So I think of that when I'm thinking about social justice. Thinking about equity, I love this cartoon because it's really gets at this issue of equity. When we even think about terms like affirmative action, on the left of the screen, you see what's considered equality. Everyone got the same thing. So just imagine that these 3 kids or adults, they can be anything in your imagination, but we have one that is differently abled in a wheelchair. We have a young lady who is short, and we have a tall man. And let's just say that they're all watching this soccer game, and they all are equally equipped with being able to keep track of the scores and assess the game and call out any fouls or anything. But there's a major issue, right? Only one of them, they all got a box, but the tall guy already could see above the fence, to assess the game, and the box just gives some extra advantage. The young lady is short; she's barely hanging over the fence, but may be able to see just a little bit. And then the person in the wheelchair can't see at all. Doesn't mean there's less skill set there, but I mean, just can't get on top of the box with the wheelchair. So you go over to the equity side of the screen on the right, and it's really about fairness. Each of them have the ability to do the task, but are they equipped with the things to make it fair so that they can achieve the goal? And that's what we're talking about when we talk about equity. So thinking about equity, thinking about social justice really made me think about the past few years, really in the context of the pandemic and all of the news. We have plenty of time to watch the news and watch TV during that time, and thankfully for the sense of bringing us to really paying more attention to some of the things that have been going on, such as the Black maternal mortality crisis. But all the news during the pandemic was about, well, what is being done to address racial disparities in maternal health, and why is there still so far to go? Most recently, the New York Times put out an article, this was just a week ago, Racism and Sexism Underlie Higher Maternal Death Rates for Black Women, according to the United Nations. And so there's been a lot of attention, finally, addressing maternal health and the just ridiculous and unfortunate rates of maternal mortality amongst Black women. And glad that there's more attention to it, but we got to take a step further. We need to do more about it. With that said, though, Black maternal health, just giving some background here because it ties directly into perinatal mental health. According to this analysis by the United Nations just a week ago, the disparities in healthcare for Black birthing people, including severe complications and death, are due to systemic racism and sexism in medical system, not genetics or lifestyle choices alone. So I don't know about you guys, but I saw this report and nothing new. It's not like we don't know that racism has been leading the charge, and how Black women are their health outcomes. Nor are we surprised by sexism, but it was still somewhat of a blow, because if we are left to only have racism and sexism as the reason Black women are dying so much more than their non-Black counterparts, and there is nothing else that is really tied to this, then, we got a long way to go. It almost feels hopeless. But I will get back to hope in a second. But just reading that was like, wow, it's really unfortunate that at the end of the day, when they accounted for different variables, racism and sexism were the main two variables that were leading the rates of maternal mortality amongst Black women. And I want to take a moment to explain my language too. I meant to do that earlier in terms of intersectionality. So when I say Black women in this talk, I am intentionally using women because a lot of the data has not addressed any type of intersectionality. So birthing people, different sexual orientations, that just has not, unfortunately, has not been addressed in the research. Another major gap in this data and in the studies thus far. So a lot of studies have studied persons who self-identify as women, or they assumed self-identified as women. So when I'm using women, it's mainly because that is how the data has been presented so far. So I just wanted to address that. But before I move on, in the Americas, according to the United Nations report, maternal health worsened between 2016 and 2020, with the maternal mortality rate increasing 15% in Latin America and the Caribbean, and increasing 17% in North America, with disproportionate worsening among birthing people of African descent. So when we looked at, when the United Nations looked at 15 women 15 to 49 years of age, and compared Afro descendants to non-Afro descendants, you can see in these three countries, Colombia, United States, and Suriname, that the rates of Afro descendant deaths were much higher, pregnancy-related deaths were much higher in each country than they were compared to non-Afro descendants. And in fact, the United States, although lesser deaths overall, they had the greatest difference or the greatest disparity. So those that were Afro descendants had 3 times the rate of pregnancy-related deaths compared to those who are non-Afro descendants. So we know that across the Americas, cardiovascular conditions are a leading cause of preventable pregnancy-related deaths, and the rate of these conditions are 5 times higher in Black women compared to their white counterparts, 5 times higher. That's huge. Disparity persists despite socioeconomic status. And in the US, as I mentioned, the rate of maternal death in Black women is 3 times greater than that of white women while pregnant through 42 days post-delivery. Now, when we get to Black Canadian pregnancy-related mortality, me being new to Canada, I was shocked to learn that there isn't any data telling us pregnancy-related mortality in general, but definitely there's not enough data in general. I won't say there's not any data in general, but there is not a surveillance that is keeping track of this in a very systemic, rigorous way. But when you get to looking at race-based, there's nothing. There isn't any established, reliable national surveillance system. And within that, there's a lack of race-based data to address any disparities, which is a major problem. We can assume, anecdotally, we know that there's disparities and that those of Afro descent are dying at higher rates, but without the data, there's nothing we can do to really move any initiatives forward or to really address the disparity. So that's a major gap in Canada. This prevents the ability to really develop policies and initiatives to achieve social justice. So that brings us to Black maternal mental health. So just to level set here, perinatal mental health disorders, we're talking about most commonly depression, anxiety, but this can also include psychosis and bipolar disorder, and that can also, it definitely includes. And it is one of the most common complications of birth, like one of the most common. So globally, we know that approximately 1 in 5 women experience a mental disorder during pregnancy or within the first year after birth. About 20% will experience suicidal ideation or attempt suicide, which is a leading cause of maternal death, third leading cause. We also know that untreated mental illness leads to poor pregnancy and infant outcomes. So what are we talking about? We're talking about preeclampsia, the same illness that leads to death in Black women, pregnancy-related death in Black women, placental abnormalities, antepartum hemorrhage, but it also significantly impacts the fetus. Increased risk for offspring mental disorders and eye and ear and respiratory, digestive, skin, musculoskeletal, and genital urinary diseases, fetal distress, low birth weight, preterm birth, neonatal hypoglycemia, stillbirth and congenital defects, and increased risk for congenital malformations such as cleft palate and cleft lip. So this is not something that there's no consequence for, which is something I continue to also educate people about as we continue to try to break down the stigma of mental health in general. But mental health problems experienced in pregnancy and in postpartum have lasting effects on the health outcomes of the person having the child, as well as on the infant. In fact, we know that long-term effects on the child include cognitive and social emotional development issues, behavioral issues, family functioning problems, and increases the risk of the development of mental illness for the infant. So what does that mean for Black perinatal people? The rate of postpartum depression, as far as we can tell, is 40% in Black perinatal people, double that of the general population. And 40% is like an estimate that is an estimate. Some studies rate as low as there's no difference. Some studies are rating as high as there's a 70% rate of postpartum depression in Black perinatal people. The best data we have seems to be somewhere in the middle. We know that structural as well as social determinants, such as poor social support, lack of access to medical care, and trauma impact the rate of perinatal mental illness. And as I've already shared, similarly to consistent with the report that came out with the United Nations, sexism and anti-Black racism has a significant impact on this as well. Black perinatal people are less likely to be diagnosed or receive treatment. There's a lot of data indicating that, and they disproportionately face poor social support, lack of access to medical care, history of untreated depression, and trauma. Trauma being a huge risk factor for perinatal mental illness. So the rate of suicide in Black perinatal people, it has tripled over the past decade. Death by suicide after birth tripled in 2020 compared to 2017, the period of 2017 to 2019, according to the United Kingdom Confidential Inquiry into Maternal Death. So this is in Britain. And they found that the greatest increase was among those of low socioeconomic status and younger age. Mental illness, interpersonal violence, and substance use were associated with increased rates. In the US, according to the CDC, approximately 23% of pregnancy-related deaths among non-Hispanic Black women were related to mental health disorders, making mental health-related death a leading preventable cause in this population. And there's also been studies that show that all racial ethnic groups of women in the third trimester are less likely to be suicidal relative to Black non-Hispanic women. So that's, I personally can say that is just striking and very disconcerting. The rate of suicide and the fact that many states are, states in the US, but many countries such as Canada are not keeping track of this data, especially as it relates to race. So there are many research limitations or just, to just analyze and understand how big the problem is or characterize the problem. Many states in the US, as well as some countries, do not have a surveillance for maternal mortality. Additionally, if a death is ruled accidental, it's not counted, or incidental is not counted. Death by drug overdose is often not addressed separately. So, and although that can be related to a mental illness, it's lumped in a way that it's hard to tease out those who were suicidal but did not have a substance involved, or did not maybe accidentally overdose. As I mentioned, it's not analyzed by race, and the data framework often approaches the Black community as if it's monolithic, which is a problem, because when we look at a lot of the data, it's focused on low socioeconomic communities where there might be many other confounders that impact mental health, but also we're not thinking about all the many backgrounds. When I think about the Canada community and the data that's cited up here, often from the U.S., I'm like, the U.S. and Canada are very different in their demographic makeup of the Black community. So there's a lot more people having backgrounds from the Caribbean and mixed with those coming from Africa, mixed with those coming from the U.S., mixed with those who are third generation Canadians or something. So there's a lot of different backgrounds, just with the people who reside here, but also people who are immigrating or refugees. So a lot more mixture of background, and yet there's just this kind of It's very simple. All socioeconomic, it's like all the stereotypes in the research. Anything that Black communities have been stereotyped to be, that's kind of the population that they study. And there's no sense of, oh, well, some people are educated actually, or some people do, have resources, or everyone's not from the same community. So that's a major drawback. So I've kind of discussed this. Intersectional identities is another thing that's not addressed, such as immigrant status or sexual orientation, and that's very specific to the U.S. Social determinants of health, though, often aren't teased out. They're treated as like, oh, well, of course, they don't graduate from high school, and not that there's anything wrong if that is the case, but there's such a wide range of background in the Black community. So to assume that one study in one community of one social demographic makeup captures everybody and is generalizable to everybody is a major gap. But the structural determinants that exist in different systems across the world are also not addressed. So the US framework is very different from the Canadian governmental framework. You can just speak of insurance, for example. And so that being a major structural determinant not addressed in terms of access to perinatal mental health care. Which brings me to Canada. When I began doing this work up here and looking into, trying to get grants and trying to see what the current prevalence of perinatal mental illness is in the Black community, I honestly was quite surprised to find that most of the data that I can find, if even on canadastatistics.com, is citing, you follow the links, it cites back to something from the US. And I'm already, I know that data well, and that data is lacking in many, many ways, but it also does not reflect the Canadian community. So that's a major gap. And then just the lack of collection of demographics in many places in Canada makes it hard to address this issue. So the UN said, I shared this because it really got at the heart of what I'm trying to do in my work. They stated that there is a dearth of quality health data disaggregated by race and gender collected and analyzed. As a result, any poor maternal, sexual, and reproductive health outcomes for women and girls of African descent remain invisible in many countries of the Americas. And that's exactly the point. It's like, well, yeah, do we know that there are disparities? Absolutely. But without the ability to quantify, characterize, it really remains invisible, and we remain invisible in terms of understanding what is going on with our maternal health and maternal mental health. So with that said, how do we begin to dismantle disparities and establish equitable care? So social justice is critical for perinatal mental health and maternal health in general. It requires that we address structural sexism, racism, and discrimination of any group. I find hope in that, although dismantling racism or sexism is not going to happen overnight, there are things we can be doing now that can begin to chip away at that. And so collecting and analyzing race and gender-based data in our studies, addressing intersectionality when we do research, accounting for social determinants of health and varying structures, and addressing the diversity within the Black community. And that's something, whether we're doing community work, whether we're doing research, whether we're teaching, these are things we can be doing to help bridge this gap. So with this slide, I share with you a framework that I adapted from a couple of frameworks that are out there, but this is reflecting the Canadian history and climate. So we're looking at slavery, social exclusion, the West Indian scheme, and racial segregation as structural determinants of health that have informed and led to the trickle down of the social determinants of health, such as income, immigration status, education, unemployment or employment, healthcare access and service, and living environment. You'll notice that anti-Black racism and sexism are listed on the outside of the social determinants of health because they function as both structural and social determinants of health, impacting Black maternal mental health and Black maternal mental health ultimately impacting maternal health outcomes. So the things that we can begin to do, collecting local demographic data and programs serving patients from multiple backgrounds or from the same background for that matter. So something I'm doing right now at the Women's College Hospital, the Reproductive Life Stages program, is I established collecting demographic data. I was like, how can we characterize a problem that we can't characterize? How can we address disparity when we don't know exactly what the disparity is or how significant it is or anything. So I recently was able to complete a application for a quality improvement project. I got it approved with lots of discussion with the hospital and the program. And we're now collecting demographic data just in our program, although there's a rollout in Toronto for hospitals to start doing this, but they're also kind of battling with, well, how do we govern the data? In our program, the reason we can collect the demographic data is because we're a psychiatry program. And my argument is that in psychiatry, everyone's bringing their culture, their background, their race, their ethnicity into the room. And if I don't understand that as a psychiatrist, then there's a gap in my treatment. So it's typical, or should be, at least in my training, it's typical that we ask and learn about, where are you from? Just as even as a psychiatrist, prescribing medication involves really understanding the patient. It's not just, handing out pills. So with that, we were able to really basically say, well, we're already doing this. We already asked these questions. And can we just standardize it or formalize it so that we can also go back and query the data to determine, well, how many people who identify as Black for this clinic, very specialty clinic focused on perinatal mental health, how often do they access this clinic? What are their experiences in this clinic? And what are the health outcomes in this clinic? With that, I'm also building on a qualitative and quantitative interviews. So looking at focus groups and individual interviews about patient experiences and, did they feel like it was a safe space? Is there a reason they were lost to follow up, or is there a reason they keep coming back? Do they feel comfortable with psychotherapy? How do they feel about medications, and et cetera? Another part of my Black maternal mental health research and clinical program is utilizing provincial and national data. So although locally there wasn't demographics being collected in many places here, provincial and national data has collected race, hasn't broken it down. Much subpopulations have concerns about the fact that when I look at other communities, such as the Asian community, I think it's at least broken down some, so that you're like, okay, East Asia, North Asia, et cetera, and then they break down the countries within those groups. But for the Black community, despite it being so diverse, appears just Black. So I've also pushed to break that down into, can we say, Caribbean or African, African American, so on and so forth. But thankfully, we at least have race data in the provincial and national databases. And I'm able to do some gender-based analyses on pregnancy, birth, and mental health outcomes. So that's up and coming. And again, even with that, involving the community as we and partnering with them as we pursue this data, analyze it, and begin to interpret it. And finally, partnering, nice segue into partnering with community organizations serving childbearing age birthing persons. So I really think it's so important in the work that I'm doing to educate and make aware of perinatal mental illness by partnering with programs to just have educational series just to talk about it. It also offers me an opportunity to learn the needs of the community and what people are experiencing, and the opportunity for partnerships and collaborations for research. So, in review, social injustice. Having maternal mental health disparities without characterization to address them leaves persons of African descent invisible, and a lack of action to address the inequity. Dismantling disparities begins with collecting and analyzing race-based data and establishing equity. Community partnerships and race-based data can be used to inform preventive interventions, initiatives, and policies. So with that said, that brings me to any questions, and I'm looking forward to the discussion. Stop sharing my screen. Oh, and that's my email address if anyone wants to contact me after this talk.